Or
The questions are invited in the chat box. We'll take it up to the panel. Next slide. Next slide, please. I'm handing over the session to the chairman of this program, Professor Dr. Tufan Gati sir. Over to you, sir.
Thank you, Dr. Ali. Thank you very much. And this is a very exciting episode, and we're going to listen to Dr. Rukseda. Hope to be a vibrant deliberation. Next, I also take this privilege to welcome Dr. Amrit Patadasi, IPS Secretary, Dr. Alim Siddiqui, Treasurer of IPS, and vibrant Dr. Vishal Chabra from New Delhi as moderators and extremely essential members of the state. Next slide, please. We have got our chairman. He does not need any introduction, and he has not sent anything. He pursued MBBS in Hindi and psychiatry and did PhD, as he was telling now. He is professor of psychiatry at RIMS Imphal, Manipur. He is president of IPS Eastern General Branch. Welcome, Dr. Singh. Next slide, please. Dr. Archana Singh is our other chairman. She did MBBS from Kolkata National Medical College and ex-assistant honorary general secretary of IPS, owner cum director of the Divyans Neuropsychiatry Center in Patna, assistant professor NSMCH Patna, membership profile, life fellow, IMA, IPS, IAPP, and Addiction Psychiatry Society of India. Is she member of Wisdom Indian Psychiatric Society, chairman membership committee, IPS Pataliputra Psychiatric Society, Bihar State Branch, organizing secretary, IPS Wisdom PGCME 2022, nominated member of the State Working Committee of IME Bihar State Branch, areas of interest, child and adolescent psychiatry, women mental health, addiction psychiatry, school mental health, awards, Youth Icon of Bihar, 2017 and 2018 in tandem, Outlook Visionaries of Bihar Award 2021, National President Special Appreciation Awards, IMA 2021, India Today's Icons of India Award 2022, and the Week's Pioneer of India Award 2024. Welcome, Dr. Archana. Welcome, Professor Singh. Please kindly take over the meeting hereafter, introduce the faculties, and introduce the topic. Over to the chairpersons. Please take over. Who will introduce? I think, Archana, can you introduce Dr. Ruskeda?
Yes, sir. Sure. It will be my pleasure to introduce Dr. Rukseda. She's psychiatrist and psychotherapist, founder of Trellis Family Center. She's specialist in adolescent, young adult, and women and families. She's president of Bombay Psychiatric Society, vice president Indian Association of Biological Psychiatry. She's co-chair of School Mental Health Indian Psychiatric Society, committee chair of Digital IPS West Zone Branch, advisor led by Foundation Family First Guidance Center, co-chair CIWN Maharashtra, studied and trained undergraduate at Lokmanya Tilak Municipal Medical College and Hospital, Sion, Mumbai, psychiatric training, GS Medical College and KEM Hospital, Mumbai, WHO Fellowship in Psychosocial Rehab, Yongin, South Korea. She's author, original and review articles, chapter contributions in textbook, media expert and TEDx speaker, passion project Yami, a support group for young adults. She loves to laugh, can't sing and won't cook. A very nice introduction, and welcome you, ma'am, on this 105th music session, and we are eager to listen to you. I'll hand over to Dr. Lin Singh to set the context and talk about the topic. Sir, unmute yourself. Sir, you're muted.
Dr. Lilin Singh, you are muted. Please unmute yourself.
Hello.
Hello. Yes, you
Yes,
are
sir.
now.
Yes.
Once again, good evening. This is the 205th edition of Thursday Musing. It is wonderful, such a long journey of Thursday Musings. And I would like to give my respects to our Tufan Pati sir, Amrit, Alim, and Dr. Sabra, and also my co-chair Archana for doing the introduction of our today's speaker. Today's topic is very relevant, especially in the last 2 weeks. There are lots of sexual assaults in our country. And in our country, we used to respect our women folk, but on the contrary, the domestic violence and sexual assault on the women are not decreasing. If I quote, in 2022, that National Bureau of Crime says that 86 rape cases per day. That is too high a figure to be swallowed as a fact. And also, other sexual assaults are more than 1 lakh in the last report of the 2022. And the conviction rate is as low as 30%. So we know that the physical assault will be healed sooner or later, but the sexual assault, especially the rape cases, the victims are left with an indelible mark in their psyche, and especially destroys up to the soul. So we have to be very, everyone must take responsibility for preventing and protecting our women folk, especially in the workplace. And now today's topic is how to approach clinically those subjects who are subjected to sexual assault. This is a very important topic for all of us. And we seldom talk about this. So for this topic, I would like to invite today's uh, the best orator in the country, one of the best orator, Dr. Ruxada Saida. Kindly share your expertise with all the listeners of today's Thursday Musings. Welcome.
Please
Thank you.
unmute.
Thank you so much, Dr. Lennon and Dr. Archana. I'm indeed lost for words with such high praise coming from luminaries of our Indian Psychiatric Society. Thank you so much at the outset to the organizers of Thursday Musing for even thinking of such a timely topic. And yes, because all of us have been so disturbed and have been involved in so many activities regarding at the aftermath of the unfortunate incident, that I think all of us are even short on time. With that, I'm going to make my first disclaimer that I'm really passionate about the topic, and I do know that I should do justice to the topic, but I'm also going to apologize to begin with that I might not be able to. So I beg patience from everybody, because this is something that is so important for us to do, but also it might not be that easy for all of us to handle. I think I have, yes. So I'm hoping that I'm visible and everybody can see my slides.
Yeah, we can.
At the outset, again, I thank my junior as well as senior colleagues, Dr. Vaibhavi, Dr. Prerna, Dr. Jyoti, and Dr. Prabhachandra, and a lot of other especially women psychiatrists who have contributed to what I'm going to speak today, just because this was such a heavy topic that, we all kind of like pulled in our ideas and insights. Trigger alert, because like I said, especially given the aftermath of the episode, if any of us is going to be feeling overwhelmed, please do a self-check, take a break, log out if you need to, reach out to somebody that you think that you need to speak to, and that can, be comforting either during the presentation or after the presentation as well, because if we don't take care of ourselves, we're really no good to anybody else. And yes, we understand that as healthcare professionals and as psychiatrists, particularly mental health professionals, particularly, this what we deal with, the aspect of sexual assault that we deal with is very, very hard hitting and very heavy. So please do take care of yourself. I'm going to try and cover some of the topics because when we say clinical approach, there is no such thing that, oh, this doesn't cover this, or this aspect doesn't cover it. Everything is important. And I always find it challenging when I have too short a period of time or too long a period of time to do justice to a topic. When when we're looking at terminologies, right? When we talk about sexual violence, or when we are talking about when we're talking about abuse, or when we're talking about harassment, what are the, what do we understand? Because we tend to use these words very interchangeably, right? But we definitely go back to WHO, the intentional use of physical force or power, threatened or actual, against oneself, another person, or against a group or community, that either results in or has a high likelihood of resulting in injury, death, psychological harm, maldevelopment, or deprivation. So that's violence for us. But when we're talking about again, violence of like the nature of the violence in terms of self-directed, like I said, interpersonal, collective, then there's physical, sexual, psychological, and developmental deprivation. But what I always tell people is that any kind of violence, any kind of abuse, any kind of harassment is always going to leave a psychological and a psychiatric imprint. So whether we talk about verbal, physical, social, financial, sexual, they're all going to lead to psychiatric sequelae and psychological distress. So what do we say, assault or harassment? Again, like I said, because we use these words interchangeably, and it's okay for us to do that, even in a clinical setting, but we might want to understand a little bit, because this also comes with a lot of legal parameters as well. So harassment is a broad term, broader than abuse. It again encompasses all forms, verbal, physical, emotional, and abuse is usually when we think about like only a physical act, again, sexual or otherwise. And harassment refers to words or behaviors that threatens or intimidates or demeans a person. Harassment is unwanted, uninvited, unwelcome, and all of, whether with whichever area that we're looking at home, on the public spaces, at workplace. So again, just because we want to be a little bit clearer in terms of our approach, both for our safety as well as our patient safety, we definitely want to, relearn or revisit some of these terminologies. Over the period of the discourse today, we will use words like patients and survivors or victims interchangeably, but you will pardon me if I only use patient, because we're looking at it from a clinical point of view today. The reason that we say survivor or victim is because some people do not want to be associated with that term, because that does not help them overcome their trauma. So they would rather say survivor. So again, we want to be respectful of what how the other person wants to perceive the event, or also want to address the event. But we as healthcare professionals are perfectly okay, and we can and should use words like patients, and it's perfectly okay for us to do that. So when we talk about assault and, the act of causing physical harm to a person, in some legal definitions, a threat or attempt to do so. So in the terminology of law, again, like I said, these are important aspects. And of course, there are various sections that deal with the different kinds of assault and harassment. When we talk about sexual assault, just like Dr. Lennon also mentioned certain aspects of the IPC section, what a sexual assault is. It's a criminal force towards a woman with intention to outrage her modesty. Then there are other section that talks about intention of insulting the modesty of a woman by word, gesture, or act. However, the offense of sexual harassment was inserted by in IPC by the Criminal Law Amendment of 2013, stating that the sexual harassment is the unwelcome physical contact and advances or demands or request for sexual favors, or showing pornography or making sexual colored remarks. So sexual violence against refers to again, any act that covers sexual act. Of course, we understand POCSO will define abuse and sexual violence in slightly more encompassing definition, and that's again something that we need to be aware. We need to remind ourselves that that will also apply to adults in most of our situations. The definition of rape is, of course, we are quoting the legal aspect here, and there are still some kind of discussions or debates about the age of consent, and what kind of relationship or what kind of act may be termed as rape. But for the sake of our discourse today, we'll define it as the way it's defined in IPC: sexual intercourse with a woman against her will, without her consent, by coercion, misrepresentation, or fraud, or at a time when she has been intoxicated or duped, or is of unsound mental health, and in any case, if she is under 18 years of age. We will again also use more the female gender and use she as a pronoun, not to exclude other genders or men for that matter from our discussion today. Having said that, because we understand that there are more women subjected to sexual violence and there are more women who also report sexual violence, just for the ease of it, I would again have this disclaimer that we're going to use she, but it can be interpreted to any person of any gender, however they identify. Again, there are different kinds of sexual violence: coercive penetrative, attempted penetration, drug facilitated, threats of sexual violence, unwanted sexual advances, sexual harassment, incest, sexual intercourse without the spouse's consent, marital rape, and child sexual abuse. Dr. Lennon again did mention some of these statistics, which are again, alarming by itself. And the reason that we do want to understand these statistics is because while we may be so taken over with our everyday, daily kind of routine work, but these statistics kind of remind us that we may be actually missing more victims or survivors or patients presenting with certain issues than we might recognize, just because there's such a large number of people who are being subjected to something like this. So it's important for us to kind of keep that in mind, that there are an overwhelming number of people who are going to present to us with these episodes and with these events in their life, and some of them may come to us with presenting with these complaints, or some of us may discover it while a routine intake. I know I, for a fact, will, at my first intake, will always ask for abuse, even if it is a child. Of course, if it's underage, it's in presence of parents or something. And of course, you take a call in terms of when to ask how these kind of sensitive questions, but you do want to ask. So a lot of the times, a person presenting with sexual assault may not be coming to you for it particularly, and you may discover it while speaking to them. And that's why, again, like I said, the statistics, me quoting the statistics there was an aim behind it, that we want to keep that in mind with anybody that we are speaking to and we're coming across. We understand the impact of sexual violence, right? We know the physical effects, we know the psychological effects, we know the immediate effects, and we also know the long-term effects. And that's why when we see that so much of one event it can trigger so many other illnesses, that's why also for all mental health professionals is particularly this is something that we want to keep in mind, that when we are looking, suppose even if you're seeing somebody for the first time and and they're presenting in an acute case, we do want to remember the sequelae. We do want to know that how we deal with the person today, right now, what the person is suffering or what the person is experiencing is going to be impactful in the long run as well. And this is a crucial moment where in the trajectory of this person's health as well as mental health. So also of concern that we often forget is the exposure of traumatic experiences of others, which can lead to secondary traumatization or secondary traumatic stress. We do use words like secondary PTSD, secondary minor PTSD, or secondary major PTSD. That's one of the reasons that I also had a trigger alert right in the beginning of my presentation, because the witnessing of the trauma could be visual, could be something that just because it happened to somebody that I'm close to or I was connected to. So that can also lead to secondary traumatization. And of course, not to take away from the fact that when we are some of us who may have experienced some kind of sexual harassment, even though it may not have amounted to assault, have already been triggered. So I'm also assuming, just like me, in my practice, that I'm noticing that many people are coming forward with this because they're getting either flashbacks or they're getting PTSDs getting triggered, or even if they're pre-existing patients and, they'll probably come and tell you, doc, I didn't tell you this, but with all of this that's going on, this has resurfaced. So a lot of times that does happen, even if you've been working with someone for a number of period of years or months. They may not have disclosed certain information, even if you have asked, which we know in psychiatry is pretty common. So that's why, again, it's important for us to, again, keep a check on ourselves, but also look at other people. And one of the major reasons that we are also going to not just focus on, yes, primarily focus on the patient who's presenting, but also the people who are with them, because they could also potentially be in, be in a vulnerable position for developing psychosocial, psychosomatic, and various psychiatric issues. Um, how does a patient come to us, right? We know that the different pathways and how they'll come to us. They might come to a patient might come directly. They might be, because when they have, especially if they have just been subjected, or whenever they might reach a healthcare facility, whether it's a hospital, private sector, public sector, or a clinic where they think that they might feel a little safe or they might get some help. They could be brought, very often they're also brought by police, or sometimes they're, sent in for evaluation by the court. So a lot of the times, again, we don't know when the person might present to us and in which settings, but we do know that usually these are the few ways that they will arrive to us, and when they reach us. So as soon as, we see a victim, a patient of assault, especially if it's an emergency unit, we should activate, certain systems get activated, right? Again, we look at medical, we look at forensic, and we look at mental health interventions, and almost simultaneously, for that matter. So if a person comes directly to the hospital without police, the hospital is bound to provide treatment, definitely conduct a medical examination with the consent of the survivor, or whoever's accompanying, a parent or a relative or a guardian. No police requisition is required for this. Having said that, this is something that we definitely need to document. And of course, we encourage all of us to document everything, but especially when we are talking about a case like this, we want to document for everyone's sake, definitely the patient's sake, but also for us, because when we have these kind of boundaries and we're working within those boundaries, it allows us to do better care. Now, I'm going to invite my young colleague, Dr. Prerna, to talk a little bit in detail. She has a very good background of forensics and has dealt with a number of cases of sexual assault. Dr. Prerna, if you want to take over.
Yeah. Thank you so much, Mal. Thank you so much for having me here. So, just to start with, all of us have a real struggle. So, whenever we have someone presenting with sexual assault or violence, what's the first thought that we get? I'm sure all of us get thoughts, oh my God, now what next? Should we document or not document? Or what should we be doing the next? And the struggle is quite real. While all of us have best interests of the patient in our mind, but I see a lot of inertia when there is some patient which has medico-legal which is a medico-legal case. And I think it's because the reasons are twofold. One is that we fear what will be the consequence for we as practitioners. And second is unawareness around what can we do. So I'm here to discuss more about what can we do. So there can be two ways in which a patient can present. One is a government setup, and most of the time in government setups, there is quite a robust mechanisms of referral, and there are, as Madam said, there are two ways in which a patient or a survivor can present to a government setup. That would be through a court order, or a police may get the survivor with them. And in that case, as per if a physical examination needs to be done, it will be a very clear referral, and there will be a clear procedure, and gynecology will take over. That will be for evidence collection. But next comes patient's mental health, which unfortunately is not the priority in the initial 24 hours, and patient may present to us later. And we as professionals or psychiatrists, our job will be to provide the best uh, mental health care that we can provide to the patient or the survivor. Uh, but if in a government setup, a lot many times the survivor comes years after, when there is no space for any physical examination as evidence, and it is more a therapeutic concern from the patient, like Madam said, PTSD, depression, and so much sequelae of what the survivor has gone through. Now the question is what as psychiatrists we should do at that point of time. And I believe a lot of us just give a diagnosis, we give medications, and a lot many times we choose to not document the history. So I'm here to tell that we should be fearless, okay, and we should be fearless to document. And the first thing is that apart once we are done with the clinical and therapeutic part, we need to offer the patient the option of filing an FIR. The patient may say, no, I do not want to take this further, and we can just document that there is an informed refusal to file an FIR. And it's as simple as that. And there is nothing else that needs to be done when an adult presents to us. In a government setup, there is a facility of MLC as well, which we can, and it is a very clear procedure. We also need to understand that there is a difference between MLC and filing an FIR. So MLC as a spirit, it's for the greater good of the society. I know ground reality is quite different, but the greater essence of MLC is saving others from similar acts. So if there is a perpetrator, something has happened, and we know that several such women have been reported to, uh, uh, they have faced assault from the same person. So MLC is for the greater good, for law to protect others from the harm, while FIR is an individual's own choice. Okay, so that is one thing that we need to be clear in our minds. And even if someone presents later, we can document the survivor was given option of filing an FIR, and there is an informed refusal. It is always better to have a third person as a witness to that. It is a good practice that if we have another colleague attesting to that the patient has refused for an FIR, and otherwise also that's okay. Now, the major challenge comes when someone is practicing in a private setup, and a person who has and a survivor has come to us within, very recent, let's say within 24 hours. What we as a psychiatrist can do. First thing is, our main focus should always be to see survivor as a person and provide emergency care. Our first focus is not to collect evidence. Our first focus is not to get fearful and just focus where we can refer the patient, or what to do just to redirect this patient. The first focus should be, does that person need any emergency treatment? Because law will be forgiving if you are able to treat the patient and not collect evidence. But law will be unforgiving if we are not able to provide emergency care and we are busy in collecting evidence or forcing the patient to give evidence. So we need to be very clear till the time patient is getting the care which any person in our situation, any practitioner in our situation will give. We are, safe, we are good from law point of view, and we are also doing best for the patient. So one is emergency care. The second is we as psychiatrists are not very much trained in collecting physical evidence. And also, I was speaking with one of my colleagues who is in forensic medicine. So there is something called rape kits, which are distributed in government setups to collect physical evidence. And there is a lot of, there is a proper way to do that. And we as psychiatrists might not have done, a lot of us. So the view and the best practice will be to refer to a government setup, and I also uh, talked with him a length of, has it happened that any person who is not a gynecologist, any medical practitioner who is in private, he has collected physical evidence and taken it forward, and he said not in his knowledge at all. So the practice of referring to a government hospital or setup is very much acceptable. So that should be the next step. The other way of someone could present to a private setup is when, again, there is no space of any physical evidence as such, but someone is presenting like with trauma and years after. Or what's the best step? So again, the best step is if we have a system of in standalone clinics as well, doing an MLC, very good. If not, you can refer to something called as one-stop centers. And the best way to do this is to prepare ourselves, and how all we all as psychiatrists can just look online and check what is the nearest one-stop center. We can find a phone number or email, maybe just a call or something, to figure out and just be in coordination with them and in communication with them. If some of the case like this comes, what's the best way to communicate? Is it email? Is it call? And they are best at taking it over from them, because they make sure that the survivor has survivor doesn't have to run here and there, go for this examination to gynecologist, go for that examination to psychiatrist, go for third examination to some other place. So they make sure that the survivor is provided best support, not just with respect to these tests and examination, but also social support. So that is the other thing that we can do. A lot many times, some people have tried to go an extra mile and try to help the survivor with an FIR, and it becomes a bit complex and challenging as well. So what the challenge here has been, first is where to file an FIR, whom to contact, which police officer to report. That have been very real questions. So unfortunately, FIR is filed where the event happened, and it may not really be where we are. That is the first challenge. Second is how to report. Okay, so there are two things with respect to reporting again. Uh, who is presenting to us? If someone above 18 is presenting to us, it is mandatory reporting is not there in the law. So we are not obligated by law to mandatorily report. However, it is best practice to do an MLC. And give adequate information to the survivor that this is how you can do it. Now the question comes to, if someone is below 18 and there is mandatory reporting, that means law says anyone who knows. It's not even a practitioner or a doctor, any lay person also, if he is in a knowledge that someone below 18 is, is being abused by law, they are obligated to report. Now the question is again, how to report, where to report, and whom to report. So I understand the ground level challenges are a lot. So again, how to report, as simple as that you can, find out the phone number of the police station or the area where the event happened. You can call or you can send an email. Is there a format? Unfortunately, there is no guideline regarding any format. So the best you can do is maybe write an email and do the needful. Now the question comes about the fear. There are so many ambiguous things and so many unknown things. A lot many times police officers themselves are not knowing the law. That is actually the reality. So how to take care of ambiguity? The best thing to do is record. If you are in doubt of anything, no need to double doubt yourself. You are feeling that this is the best interest, this is the right thing to do. Just record that you did this because you felt this was the best thing to do because of this reason. And it's what we call bola man bolitho in law, that you are doing what anyone in your place will do. It doesn't matter you have resources or not. It's just the best intent that would be seen. So yeah, that's it from my side, and I'll ask Rishida ma'am to take over.
Thank you, Dr. Prerna. I think that was really, really helpful to a whole lot of us because, again, like I said, when we see a patient is not something that is entirely in our, it's not in our control. And we definitely want to be aware of what to do. Again, like I said, not just because it makes our lives easier, but it also helps the patient kind of feel more attended to and more secure, and that's one of the first things that you do want to do that. So again, medical legal assessment, timely reporting, examination, collection of forensic evidence, all of that is very, very important. And where do we do it and how do we do it is also very important. A lot of the times, yes, you may find yourself to be the only person who even knows how to carry on this kind of examination of a patient or conduct these kind of things because examinations, whether that's physical or something else. So that's why also it's important that we we make ourselves aware of it. Dr. Prerna mentioned one-stop centers, and if any of us are not aware of it, we have more than 700 one-stop centers across our country, and one is available in practically every, very nearby in some districts or the other. And these are important, again, things, just like we know so much, thankfully, about POCSO, we also need to know about this. And these are very good services that are provided for free by the government for all women who may be in who are feeling vulnerable and threatened and reach out. So it's important for us to know the services that they offer. And when it says one stop, it means actually one stop for medical, legal, social support. There are even shelters that are available for women who are running away from something or who felt threatened or who may be vulnerable in other situations, and they can be sheltered for up to 5 days with a child. If it's a girl child, then that's fine. If a boy child, then at least, till the age of 12 years of age. So the shelter part of it also really comes in pretty, it's a very important aspect because we often wonder, what do we do with this? And how do we help this person? Or, we may come across, maybe not even in our clinical setting, or somebody's calling us and asking what to do. So it's better better for us to have these kind of information. So to general principles in terms of when somebody's coming to us, again, it doesn't matter what setting you're in, it's an informed consent. When we say informed consent, the consent is not like it needs to be empathetically spoken about. We cannot like just narrate it out as a very dry. The reason I'm emphasizing on that right now is because, like I said, when we do self-check, we don't only do self-check because if we are getting triggered, but we also do a self-check that, okay, today in this moment, do I have the capacity to handle the situation in a empathetic manner where it allows the person and makes, like I said, the crucial difference between developing psychiatric issues or, reducing the risk factors for that. So that's why when we are, we may not be prepared for a case like that comes to us. And so we take a moment, it's all right. I mean, there's no hurry. When we're speaking to the patient, it's important for us to also have our body language in check, our facial expressions in check. We cannot be having a face, mask-like face. If you're a male clinician, please be aware that you need a female attendant with the patient while you're speaking to the patient or in the room. Again, for your safety, but more definitely for the victim to feel to feel a little bit more protected. Even now we tell our little children that if you are scared or if you are lost or if you're worried or you're ever in trouble, look for a woman. Because we don't even say look for a police or look for somebody else. We say look for a woman because they automatically do feel a little bit more more comfortable sharing information or sharing whatever it is that either you're asking or they want to share. Calling for family members is again important, but you do need to also again approach it in a way which is very consensual, because we are assuming that the person will be happy to see a family person there or something. Because a lot of the times, because there's so much of victim blaming going on for centuries, a lot of the times the victim, when they come to us, the patient will be involved in a lot of self-blame and guilt and might not want to, in fact, might get actually very scared or feel threatened if you say that we need to call your family. So again, even their consent and how you maybe even encourage them to reach out to somebody that they trust, that it might not be a family person, it may be a friend or a colleague that they trust at that time, so that they are there for them and they can, we can take the process forward as well. Privacy is very, very important. I understand that we live in India. We are, there's a space crunch, especially in public sectors, or frankly in private sectors as well. But this is something that we definitely want to take care of and provide that kind of privacy for this person. Because no matter which phase you might be seeing this person in, there is still some amount of shock that might be associated and might be presenting. Of course, confidentiality is very, very important. Even if we are kind of, at the end of the day, I go back home and I want to debrief and I'm speaking to somebody, I need to speak to that person without breaking confidentiality, even if I'm taking care of myself and, like I said, debriefing myself. Very important to remember again, the telling and the retelling can really take a severe toll. Dr. Ballavi from Goa was sharing that, especially for men and transgenders, that becomes more difficult. Saying it once is more difficult, but then the number of repetitions that they have to say what happened, how it happened, why it happened, not why it happened, but what happened and how it happened, and what you're feeling and what you're going through and what's hurting, what's not hurting. So that does kind of like also bring about some blunting of maybe expression of whether facial or verbal, and that might we need to understand that those are trauma responses that we are probably looking at. So when we again, restoration, the steps that we can take is restoration of psychological safety, have the patient recognize that he or she is in a hospital and is or in a healthcare system and they're safe. Though with the recent events, that seems like a little bit of a tragic and a comic, sentence right now, but we still need to be able to reassure them that they are safe wherever they are, because safety is something that is paramount in this in this moment. So if she has been brought alone by the police, definitely contact a trusted family or friend. A calm, respectful approach by the clinician will help the patient develop a sense of safety. Patient may be brought in a dissociated or stuporous state and may look apparently calm and unaffected. Again, like I said, the trauma response is something that it's important for us to remember. And documentation again is very, very important for everybody's sake. Because again, we might be in an emotional state ourselves and we may not remember or recall things later. So it's important for our caregiving for the patient, whether from a medical or psychiatric point of view, that we document as much as possible. In fact, every little thing as much as possible. So, to take it forward. So how do you actually say such things, right? How do you actually make sure that they're in a safe environment? Yes, we mental health professionals should know how to make somebody feel comforted or safe, but it's always nice to kind of relearn something or remember something. And so normalizing and validating feelings is very, very important. And it's okay for us to use such words. I know this can be hard to talk about. Thank you for telling me. Because when you are empathetic towards this way, the patient might feel a little bit more comforted. You definitely have to have a non-judgment attitude. And and you say that it's all right. And because so many times they will actually say, you don't believe me, do you? And just because I look like this, or just because I'm looking like this right now, or I'm talking like this right now, and all of that, so they might be defensive. And especially at that time, it's okay for us to say that different people respond differently. It's perfectly okay. However you're feeling, it's absolutely okay, and it's valid. And you definitely need to be compassionate about it, and you need to let them know that they're not alone. And again, in a non-threatening way, because at that time, being alone might be something that actually that they might be preferring, because that's something that we do see quite often, that they want to be left alone, even while they understand and they themselves may have approached you for care, but they also want to be left alone. So there's that dichotomy. So it's important for us to kind of take our time, not rush anybody, not rush ourselves, not rush the pace per person. Even if we know this, but having said that, I'm still going to reiterate, even if you want to maybe hold a hand or touch someone, please don't do that. That could be really very triggering to the person. And of course, it violates a whole lot of boundaries. So when they're presenting, immediately the psychological reaction, a lot of the times would be blaming themselves. They will be, a lot of the times they're numb, they'll be confused, they'll be frightened, they'll be angry, ashamed, in a daze. And we do need to be aware that there's a whole gamut of presentations that we are, when somebody comes to us, that they can present us, and we cannot be basing our judgment on that. I remember, the famous Hollywood case also, Amber Hart and Johnny Depp, and the way she's talking about it, clearly there was no abuse, and I was like, have you guys heard of trauma response? So again, we need to be careful about that. And we want to remind ourselves that, okay, we may have an idea in our head or a picture in our head that this is what a victim should present or does present as, but we definitely want to see the person and not have preconceived notions. So we're human beings. We could have biases over the years also. So we definitely want to check that as well. And then later when they present, memories of incidents can be flashing up. Living in constant fear is a huge but lowers the quality of life to an extent that it impacts functionality. They do tend to isolate themselves, and of course they can have anxiety and panic attack symptoms. There's definitely loss of trust of themselves, of others, of the system, of the world, going anywhere. So those are again things that we know that they are going to present with. And of course, functionality at workplace is also going to get impacted. I have a recent case that I've been dealing with. with over the last few a couple of months, really, before this incident even happened. This young woman who's, has a corporate job, was sexually harassed by somebody in the workplace. She also happened to meet this person outside because she thought that this was a work thing, or this is how networking is done, a whole lot of things really. And so she, the way when she presented, the reason I'm even talking about this thing is because hopefully we can just look at this one case over the next few minutes to understand the approach that we can take or should take. And as Dr. Prerna was mentioning, okay, reporting is so important, but it's important for us to remember to never tell the patient or the client or the person or the victim or survivor that, oh, you have to, you should report. Think of all of these other women that you can save. This person is, nobody is just like a single offender. They're usually serial offenders. We don't want to put that emotional burden on them for reporting. What we can do is, and I was speaking to her because there was also, like I said, that lack of trust and that apathy that comes up, right? When they will say things like, because there has been incidences in her life where there has been harassment. So of course, so I was like, and she was like, oh yeah, so this happened in the train, then I got off and I went and reported, but kya hua, kya fayda hua? So now I have reported this also, and it has gone to the POSH committee, but I feel that, why am I even doing it? So the way I answered her is that, you may think that what you did was useless and kya farak pad jayega, nothing changes. And I think a lot of us are also feeling like that. But what I told her, and that helped her almost immediately, was that every time that, you report, you may not be getting a personal justice or personal your personal grievance might not be heard, but it is adding to the statistics. And think about, even if it may be happening slowly, the number of times we report something, the number of the statistics increases. Maybe somebody will sit up and take notice, and then there may be new laws, or there may be new securities in place. There may be new, systems in place that are more efficient, and there may be more people willing to, implement those systems and laws. So again, these are important, aspects, and how we speak to somebody makes a huge amount of difference. So even though she has reported the train incident, even though she has reported the POSH, she will still have like, I don't know whether it's even like, important, or whether this is going to be helpful. And of course, there was also a lot of apathy that, yeah, I'm coming here because I think, like, rationally, I know that I should be coming and speaking to somebody, but I don't know what's happening. And so do you want to be able to let them speak and validate again that I understand, I can see that this is how you're feeling, and the repeating of that, that yes, I hear that you're saying this to me, and I can see that how this is impacting. These are words that when we use again and again, it does reassure people quite a lot. So what are the factors that may be impacting the presenting distress? Of course, the nature of the assault is very, very important. It's an important factor that we understand that if there is physical abuse or physical violence along with the sexual attack, if there was a threat to life or limb, if there was the woman or the patient was drugged, a person with them was threatened, like a family member or a colleague, that if you don't, look, we're going to harm this person and you need to cooperate, or you need to stop doing this, or you need to stop yelling. Of course, if there are more than one perpetrators involved, and of course, when their assault has been by somebody that they know, like in this case, this was a senior colleague and a person of authority, somebody that she respected, looked up to, and admired even, and thought that she's being mentored. And so, of course, those are factors that are going to increase the distress that they present with. Also, the response of the family. One of the other reasons that this particular patient is also distressed, and is that because she feels that she can't say this to her family. That no, if her family comes to know that this has happened, or she's even reported a POSH case, what they're going to say is just come back home, leave the job, because for her to leave her home and take this job and come here and live independently and work for herself was a huge battle that she had taken even before all of this. So she's like, they won't understand all of that. And her personality isn't something that she has a lot of friends. She has just maybe one or two, maybe good friends and colleagues. Thankfully, people at work are very, very aware and very proactive about it, because she's been sent from her workplace, from the corporate. She gets leave whenever she needs to see me. She gets, the sessions get reimbursed, so that there's no financial burden on her. They've taken up. So the workplace has definitely risen up to the challenge and doing all the right things. And she's, aware of it as well. But of course, being grateful is not something that she needs to be, because these are her rights and she deserves that. So we don't want to say that, oh, you're so lucky, like these people are doing this. No, they're supposed to be doing this. So that's also important, because then she feels empowered. If we are saying that, oh, you see, you're so lucky, the workplace is doing this for you, then the person feels that, okay, yes, they're still the victim, they're needy, they're receiving arms. Again, that can be disempowering. So it's important for us to say that, oh, I'm glad that your workplace is doing what it's supposed to be doing. So even a simple thing like that, a simple sentence like that, or reiterating a statement of fact, can be empowering to the patient and gives the agency back to the person. Of course, if there's no counseling that has been done, that's going to increase the issue. So number of factors really that we look into. Perpetrator issues, being out on bail, being in the same place, all of that gets very highlighted. I know that a number of my patients who may not have been assaulted themselves, but have had some kind of experiences and everything, go through a lot of setback in their psychiatric symptoms as well. When we heard news of, oh, this person is on bail, or, there are unfortunately a number of people who were even sentenced for a sexual crime, and then they get let out for bail or and then they get garlanded and all of that. That does make a lot of difference to the person, especially if, I mean, of course, if the victim herself or himself is knows that these people are out on bail, definitely has a setback in psychiatric symptoms. The media trial is also something that's very, very important, because a lot of the times, even though there are a lot of laws in place, how they are supposed to report and not supposed to report and not, do this, they will become judge and jury, and they'll start, either accusing this person or blaming this person. And of course, questions like, why was she here? Or she should not have been wearing that, or she should not be doing that. All of those things are going to be influencing this person. And no matter how much of a bubble you want to live in, a person cannot like go without doing that. And you may doom scroll, and you may be, doing that. Patients might be doing that as well. And sensitivity within the system is again something that's a huge factor that will impact how the person, the outcome of this person, whether that's the health system, the police system, the legal system, or, and how the counseling sensitivity, like if you are the person at that person, the reason that we're using the word counseling here and not psychiatric intervention is because, and the first contact, especially if it's an acute case, we're essentially not really doing beyond giving some kind of psychosocial support. So that's the reason the word counsel sensitivity instead of psychiatrist attitude is written there. Of course, past experiences of traumatic events, just like I was mentioning, this young lady, she's been touched inappropriately before. She even had incidences. So this thing that, oh, this keeps happening to me. There's something wrong with me that this keeps happening to me. And of course, then the current trauma gets compounded by past experiences and, past events. Childhood sexual abuse is definitely something that's going to complicate this, the present episode, history of psychological, of course, problem issues, or this, psychiatric illnesses, abuse, family environment, early childhood experiences, homelessness. We do see we don't see that in intersectionality, unfortunately, where we know that homeless women who live on the street, maybe they are more likely to be abused multiple times, even in the same night, by different perpetrators at different places as well. And so the abuse and sexual violence for homeless women is so much more and goes absolutely unreported. And of course, if there is that insecurity about shelter and about physical protection protection is going to be an impactful factor. Of course, physical or sensory disabilities are also going to be a factor, and intellectual disability can, definitely have a damaging impact. Again, how do we go about talking to people when they present to us? Listen patiently without interrupting, even if they ramble, and even if that doesn't, help you to kind of like write down everything. So it doesn't matter, let them go. They might be confabulating a little bit. They may be, talking about completely something very, very random, just because that's helping them kind of navigate this conversation. It's perfectly okay for them to do that. Let the silence be. Sometimes the silence can be therapeutic. Sometimes they need that time. Even somebody, when they are talking to me and they suppose start crying, I don't ask them, do you want a tissue? I might just maybe, put the tissue in front of them. So the silence is something that you, even though you may feel uncomfortable with it, but this is not about you. This is about the patient that you're seeing. It's okay if they don't want to talk about it. Definitely start with the disclaimer that you can tell me whatever you like. And even if I ask you something and you don't want to talk about it, it's okay. You can tell me you don't want to talk about it, and I'm not going to push you. So that's something that we definitely want to say to them. And, ask them, oh, do you want to talk about it? Is it helpful if I ask you questions? A lot of the times they'll be like, yeah, you ask me and I'll say yes or no. So it's okay for you to kind of do that. Believe somebody when they're saying something, because it's not your job to judge or not judge and all of that. But when you're dealing with a person who's recounting something, believe. If you're not going to believe, it's okay, even if there's somebody who's maybe, because everybody kind of goes up in arms that, oh, there's so many false reports and all of that. No, there aren't a lot of false reports. The percentage of false reporting is very, very, very minuscule. And it doesn't matter, you're not going to harm anybody by believing that person, right? So that when you're not projecting that you believe this person, that does also impact the therapeutic process. And of course, support through the procedure, provide links to support system, be helpful in whichever way that the person requires. So management in terms of, again, acute care and long term, there will probably be a requirement of psychopharmacological management. If a person is distressed, of course, then there's the question of, okay, if the person does require some medications, from a like I said, from a psychopharmacological point of view, when do you give, when do you prescribe? Because the process of the legal, the forensic, the other health examinations can be rather long and tedious, and the person might not be able to we might not be able to give them some medication. But in some cases, there could be a lot of distress and agitation maybe, and we might require to do emergency care in that sense. When we are looking at long-term psychopharmacological management, of course, it again depends on the presentation of the symptoms, if there is a diagnosis pre-existing or, recent diagnosis. And again, whether they, those are clinical decisions we need to take and treat the person accordingly. There are no guidelines in terms of this is SRI or this SGA, or, avoid this and avoid that. It entirely depends on what the person is presenting with, and clinical, guidelines according to that. When we are talking about interventions in terms of psychotherapeutic wise, once we've done the supportive therapy, once we've been there and metaphorically held their hand through all of that and been there, created that environment and safety, and hopefully reinforce some amount of trust in healthcare providers. What we do see and how we do deal with situations, CBT is something that is, of course, evidence-based. We understand there is CBT of trauma. This today is not something that we can get into a long description of it. EMDR, again, is a very, very good good intervention for trauma. There's a lot of evidence based that for traumatic experiences or memories, we do see a lot of evidence. Of course, it's again CBT backed, and that's something that if you don't think you're able to provide for that patient, but or maybe your team doesn't have somebody that's able to provide for this person, we definitely have to refer them out. But we do need to know the basics of it, so that even if there is something that the patient might not need, but the people around them might need, not CBT or EMDR in an acute situation, but definitely being supportive and being saying the right things to the people around them as well. Because like I said, one of the factors is the attitude, and the factors impacting our patient is the attitudes of their friends and families. So their friends and families are distressed, and they might be asking the wrong thing or saying the wrong thing with full, good intentions, but they can be harmful to the outcome of our patient. So that's why take a little moment, ask and check whether they require help and whether they're okay, and also let them know that it's okay, perfectly okay for them to also take care of themselves, even while they're providing support and care for their loved one. I don't know how much more time we have, because we're past 9 p.m. But we definitely want to talk about special groups. When we talk about children are subjected to sexual assault and sexual trauma. POXO is something that is not something that I thought we might discuss today, just because it's a whole different topic in itself. Elderly abuse, sexual abuse in the elderly is again something that's covered by different sections of, IPC sections as well, and will require a different kind of intervention, because there'll be probably a lot more shame and stigma and uncomfortableness when something like this happens. But it is, and a lot of the times they won't report it, and a lot of the times we won't ask. Even if we are looking at older adults as our clientele, as our patients, we usually don't ask about any kind of abuse, whether they are, we will just all assume, because we want to assume that they are well taken care of. But they could be, just because, and it doesn't matter whether the elder abuse is happening by a caretaker or by a family member or by somebody else. So that's something that's, again, it's a very, very important part of our, something that we want to, again, improve our skills in. And improving our skills essentially starts with asking the right questions in the right way at the right time. And the rest of it will follow. Of course, persons with different disabilities and LGBTQA is somebody that we know that from all the sections of adults, the LGBT are, they're abused and violated and harassed and assaulted far more in greater numbers than regular adults and other adults. So handling that with a cultural sensitivity, also humility and compassionate approach is something that's very, very important. We can go on and on, like I said, but then, and I hope that I've at least left some things that, we may have revised, or we may, left you with some kind of maybe questions and some kind of inspiration to go back and read up and maybe share with other colleagues and learn a little bit more. And with this, I'm going to, invite the organizers and the chair people to take over. And if there are, so thank you so much.
Thank you so much. Thank you so much for a very delicate handling of a delicate topic. So now we are more learned than before. Uh, Inviting chairpersons for their opening remarks.
So you're on mute, sir.
Will there be any the interaction session, or directly we'll go to the concluding remarks, opening remarks we have already made?
We'll take some questions,
Then
sir.
we go to questioners.
We'll take some questions, sir.
Yeah, please, Amrit, you're handling, or someone is handling the questions in the chat box.
If you want, you can also take the question. No issues, sir.
Yeah.
आप लेना चाहते हैं आप ले लीजिए, हम लोग we will conclude. सर आप ले सकते हैं. The chairperson can take the questions. We have no issues.
Chairperson can handle any way they like.
They like.
Welcome.
Alim always wants to ask questions. So
Alim, please go ahead.
Yes, sir. Thank you, sir. Thank you. So, very small and a very heavy question by Ambu Pandey. How to answer there? Why me? How to answer that?
Muted.
Uh,
Ruxada, muted.
Ruxada, you are muted.
Yeah, done.
That's a very, very common question, right? I mean, whether we all get those questions, even when we're not talking about a sexual assault case, right? Somebody with depression or anxiety or schizophrenia, they will all come and tell us these things. Of course, we might want to avoid bringing God and spirituality in it from day one, like from the minute you see this person, because you don't know whether they would appreciate it, or actually that might hinder the therapeutic process, because even when you're interviewing, it is a therapeutic process. I mean, if we handle it, it's going to be a therapeutic process. So when they do ask, okay, why me? Why this happened to me? Is, how is it? There could be, it's layered. A, it is self-blame, but B, it's also about the anger and the angst against the perpetrator as well. So we do want to focus that, okay, you know what? You're not the one who did this. That other person chose to do this, right? And it doesn't matter who that person is and why they did it. Yes, you're the one who is now in distress. Having said that, it's not your responsibility or not your blame to take. Why did this happen to you? And we want to avoid using terms like, oh, it's your bad luck, or you were in a wrong time, your wrong place at the wrong time. And you say that, yes, this does happen very, very commonly. And unfortunately, this time it happened to you. But what the important thing to do right now is to, like, try and take care of ourselves and try and figure out what we need right now, and how do we help ourselves, and how do we treat ourselves and get better from it. To again, like I said, it's important for us to maybe try and avoid moralizing or lecturing on a spiritual level. But if they do bring it up and they say that, why did God do this to me? Of course, you can answer in a more spiritually sensitive manner, and things like that. It depends on where they come from and how they come from, which cultural background they might come from. That also helps. Like, if it's a Muslim patient, we always say that, oh, God's not gonna give you more than what you can tolerate, so don't worry about it. We are there, we'll help you move past this and take care of yourself. We say things like, whatever happens, there's going to be justice, whether here or there. So those are words, again, like I said, from a cultural sensitive point of view, you could use. But yeah, it's nuanced and layered. So it's never, there's no such thing as a right answer, but there are definitely things as wrong answers to that question.
yeah, my next question to both to Dr. Rukshada and Dr. Prerna. Suppose the patient, it will be a recap of what you have already presented. So a patient comes and reports that he or she has been traumatized sexually. So as you said, the first step is to take care of the well-being. So what are the steps in that? How do we do that?
So yeah. So there are 2-3 things. One is in what setup the patient has come. Initial focus is always to provide emergency help. Then, if any clinical help is needed. And the third part is what we call, I will speak more about law and the legal thing, is the examination and the evidence collection. So like, again, it's the recap. In government setup, there are set mechanisms for that. In private setup, practically, please refer the patient to the government setup, because we are not in a place where we can do a physical examination and collect evidence. We do not have kits for that. So the best thing is to do the referral. Yeah, does that answer the question? Anything
How
else?
does the government setup handle it? What are the must do points there?
Yeah. So every institute has a mechanism. So because I have studied in KEM and have been there, so I'll just take it from there. It has also evolved. The mechanisms have evolved. So the first point of contact is MO. MO of is the or medical officer is the point of contact. Next thing is that everyone else, whoever needs to examine, comes in the emergency. Whenever the patient of assault comes, it's never patient going to gynecology, patient going to forensic medicine, patient going to psychiatrist. That's not the mechanism. The mechanism is that everyone comes to emergency and sees the patient then and there. Most of the times, initial few hours, if it is a recent assault, psychiatry unfortunately takes a back step, and the focus is more on doing, blood tests to check the well-being. One more thing I want to say is everything is consent. So if the patient has walked in, it doesn't mean that patient has walked in for physical examination. It doesn't mean patient has consented for, tests. And it doesn't mean if they have consented for tests, it's all the tests. The patient may consent, okay, I'm okay to give my, I'm okay for blood test, but I'm not okay for genital examination. We cannot force the patient, no. This is the evidence. It is my, at times we become, it may get, we may feel, no, we need to collect evidence and go ahead and do a, PV examination and all of that. No, we need to document each and every step. In government setup, uh, the gynecologists are quite trained. The Home Ministry has given a format. The forms are available. There are kits which are readily available. So that's the mechanism. The gynecologist comes, takes consent of each and every step. They collect the physical evidence. They collect the blood. If any medical support is needed, the medicine person comes. If any surgical support is needed, the surgery person comes. So that's the way it works. Yeah.
If I may add, if even if a person is presenting to us in private and we are referring them to a government setup, it's maybe a good idea to ask them, would they like us to accompany them, because that would be something that would be a ethical and responsible and even a moral thing to do. And or if and you're in a government setup and somehow the psychiatrist or a mental health professional is called in practically the same time as others, and if you have the opportunity to kind of be there, maybe ask the person that is it okay if you are with them while this is happening. And so one very easy way of looking after well-being of the person is by just narrating to them what's happening. Yes, the gynecologist will also say that, okay, can I lift your shirt now, can I examine this now? But even if they're not doing that, you could say that, why this doctor is doing this for this reason, and not in ways that confuse the person, and not just because you want a running commentary, but kind of like maybe explain to them what's happening. They might be holding on to your voice than to, to also to kind of dissociate themselves by what's happening physically. So while you're kind of telling them and comforting them, you could comfort them by saying, you're in the best possible place. I know it seems like it's taking a long time, but don't worry about it. That's only because we are taking our time as to not rush you and all of that. So even you can still contribute during that time, and that contribution can lead to a lot of positive outcomes for that person and for that traumatic event. And that might be helpful to the other medical colleagues as well, because that means that they could do their job faster and easier. And then because every job is done with keeping the patient in mind and their well-being, and protecting their medical, psychiatric as well as legal rights. So yeah, I mean, if you're lucky to be there and if the person is lucky to have you there, there's no such thing that that you can't help or you have to take a step back. Of course, you don't want to be crowding that area. So again, like Dr. Prerna said, consent is very, very important for everything. Keep asking, is it okay? Do you want me to continue speaking in this way? Do you want me to, but make it less jargony and tell them why somebody's doing and how this is better and why this is important and why this is not going to be painful and they're in good hands. So that is, continuing that kind of environment of safety and wellness is very, very important.
One thing is, how do we take care so that the patient is not re-traumatized by doing examination while asking questions? So what are the soft skills that should be followed so that we do not re-traumatize the person?
Very, very important question. Thank you so much for that. For the simple reason, while we are examining, right, there is a lot of physical contact. And depending on the experience that the person may have had, either immediately or in the past, even a simple thing like a touch on an arm or a touch on a shoulder could be very, very triggering, let alone an invasive process like PV, because, again, the person is in a vulnerable position physically, and there's something that is getting inserted, right? So it's important, again, how not to traumatize is continuously speak to the person in a tone that is very soothing, is informing and informating to them, and at every given point ask for consent, and keep telling them that why you're doing this, and giving them agency again and again, that you can stop me anytime, this is okay, you let me know whenever you feel that you're not happy with this. So continuing to kind of like do that will probably help. But if you feel that yes, the person is getting either a flashback or is very, very distressed, stop. Evidence collection, while important, and some kind of medical care, while important, may not be absolutely mandatory or very, very urgent. Not because we are only, we're psychiatrists, so we should be only taking care of psychiatric aspects of it, not at all. But this is overall for the outcome of the person's health and social well-being later. It will impact rehab and all of that. So how we will not be able to anticipate when the person might get triggered, but we definitely want to keep an eye on both verbal and non-verbal communication and signs that the person might be giving. And again, like I said, you may or may not be present while the physical examination is happening, but hopefully the doctors, the gynacs and surgeons and medical team is also trained in something like that, and they're not overly tired at the fag end of a 24 or a 36-hour duty, so that they have more patience and more compassion in them while they're doing this.
Okay. So now suppose a person comes and says that I want treatment, I want counseling, but I do not want to report for some other reasons. I may be attacked again. So what is the right way, clinical and forensic legal way in it? Patient does not want to report to the authorities, just wants treatment.
Dr. Prerna, you want to take this?
Yeah. So again, the patient is the center, and it's patient's right to refuse. And if patient is saying they do not want to report, we respect that. So again, I can see in the chat there is some confusion between what's the difference between like MLC and FIR. So again, we need to understand that MLC is as simple as medical legal case. We are labeling something as medical legal case, which means we are requesting police, please look at this. Is there anything dangerous? Is there anything that needs to be investigated? So it's like an information we are just passing on. We feel that this situation might need investigation, and we are just passing that information to the police. Okay. So that doesn't mean that something legal will happen or something the patient has to do. Patient has no role when we label something as MLC. Okay. Patient may choose that I do not want to file FIR. We respect that. We can still mark it as MLC and intimate police. I feel that this needs investigation. There is some question about confidentiality. So we need to understand that when we are trying to keep someone safe, there are certain places that confidentiality will break. But the very concept of confidentiality is to protect interests of the patient and that the patient should not be harmed. So even if we are filing an FIR, it is confidential, and but we are writing that, this was a person who had experienced this. So it's not it's not in open public. The information is not in the open public. It's between two people who are representatives of state. State means India, as in state. So a doctor and a police officer, they are like protectors of a person's right. And it looks very spirited, but in essence, when we are working in a government setup, we are entrusted by state to protect someone's right to health. Okay, so it comes with that spirit, and it's not breaking confidentiality. So we respect no FIR informed, but we need to document that informed refusal to file an FIR. Yeah, that's it.
Also, we
But
want to
MLC can be done.
Yes, it's just informing, and patient may not be involved as well.
patient need not be there. You can file an MLC that
Yes.
I'm seeing, or I saw such and such a patient
Yes.
at such and such a time, and you're just informing the authorities, in this case, the police. What also we might want to understand is that, especially if the patient is being accompanied by family, relatives, or other people, and they might be more vociferous about, oh no, we have to report it. Why you tell doctors आप इसको बताओ कि क्यों जरूरी है और ये करना चाहिए उसको वगैरह. So they might be a little bit more zealous about it at that time, and you definitely want to remind yourself and keep that in mind, that you're not providing just psychiatric care or health care, but you're also an advocate for your patient's rights at that time, because you're part of her or his team. And that might then come to, or it might come to you talking down the relative and saying that, why don't we take some moment and let's think about what is the right thing for us to do. And you can tell the patient that it's perfectly okay if you don't want to do something right now. You can also report it later. And a lot of the times, patients sometimes will also say that, okay, yes, I don't mind getting the evidence collected, but I don't want to report anything. So that might also be okay. And like Dr. Prerna said, there's a difference between MLC and FIR. The person may or may not do it later. But again, that's why how you approach it and how you speak to the person might be actually the point of where the patient might land up in terms of taking care of their legal rights or things like that. So if you're lucky to be there, and if the person is lucky to that you're there, we can guide them in this way and help them make that decision. Please understand that when a person is under trauma, whether acute or past, their decision making skills are going to get impacted. Their cognition is impacted in that level. So so we don't want to coerce consent. While we are trying to be supportive and encouraging maybe, and give them agency and empowerment, we don't want to coerce consent, and we don't allow others to coerce consent as well.
Just to add,
But if it's a reverse, most of the time it's reverse. Most of the time it's reverse. The client wants to report, the guardians don't want. And many times they discharge the patient and run away. I think it's 99% of the time it's the reverse, because anybody who has been abused is very vocal about it. They want to report. They are traumatized. They're staying in the same family, or they're seeing somebody close by doing it, and the family members try to diffuse it. Don't tell, don't report. Marriage kaise hoga? That's what I see in my setup. And if we try to force that the client is willing to put a case or we report it, they just run away with the patient. So the reverse in our setup is much more common.
Yeah.
Sir, want to make
Just
a
to
point.
keep in mind the POXO, Act. If the POXO is there, we have to inform.
In case of children. So I want to make a point here, as Dr. Prerna had said, we are labeling this case as medical legal case, and when patient is not willing to report, are we taking consent of the patient that we are going to put it to the authority, or without telling them we are going to put it to the authority? And probably if will not take the consent, then confidentiality issue will be there.
Yeah. So I'll again reiterate. MLC is sort of, patient will almost have no role for marking a case MLC. consent of patient is not needed. We need to understand it is more like an administrative process. The larger impact where the confidentiality may be broken is if we have, I think all of us might have worked in government hospital and we have marked MLCs. And most of the time, at least I have never seen any police officer coming back and inquiring. Okay. All the confidentiality clause will come if the police officer is coming back and they are asking directly to the patient, has this happened, and they are trying to investigate. Just one refusal that I do not want to get investigated, that's enough. Okay. The investigation cannot go ahead unless there is a first information report. So it is just an administrative process, is what I'm trying to tell.
Well, that's true. But the point in my question is whether if we are going to report it to the different authority, whether we are telling the patient that this is going to happen. Because when the police comes, as you stated, a hypothetical situation, when the police comes and inquire, then probably patient will ask how they pitched in into this. And when I had clearly stated that I don't want to be get into this medical legal process or being stated like that.
Yeah. So it is between we as doctors and trying to understand what is the level of understanding that a patient can have and how we are explaining it. If we are explaining it well enough, that largely this is for the greater good of the society. See, the MLC is just someone else should not be at the risk. FIR is as an individual. The individual that needs to be justice. Now the point is how we explain and how much we are able to gauge a person's what we say level of understanding. Okay. In most of the cases, what I have seen is if we are able to pacify and just tell them that this is the reason, I have not observed objection. The other point is because it comes as referral, it is already marked MLC. So if you will see most of the time, it is coming from the MO.
There can be may I submit? Okay. And there can be the right observation is that even if we do it as MLC, CRPC describes FIR, even if we tell something orally to a police officer or in writing, he can make a report of it, which will be considered a FIR. Affairs Press Information Report. When we give it, he is bound to give us a copy of that, number one. Second issue is that a patient in distress has come to me, right? And the patient is not willing to go in for the tussle because he has already gone through a strain. But the basic thing, if we in our heart of heart realize that informing the police will be in his interest, how I can explain it? He does not report, goes away. And goes to the same circumstances, the act may be repeated. So you have to be convinced that person, the distressed person who declines to be investigated, gives in writing, and he is doing in a full state of mind, and he has the capacity to understand the implications of being reported and not being reported. Otherwise, just at times we are more, if you get a consent, we send it. If we get a declared, we don't send it. But there's no fairness. Maybe some time later, someone will come and you did not report it. She was in nonplus, she told no, and you did not do it. And that is why this act has been repeated and she is no more. So these are complex situations. There can be no hands of rule for that. One has to do to the best interest of the patient and try to do it. To try to convince the patient what we think to be exact and justified is more important. That's my opinion on this. Thank you.
One way of dealing with that is that if the person has said that, no, I don't want to do anything and I don't want you to talk about any medical legal case, it's okay for you to not pursue that line of talk and go ahead with the care that you need to provide. And you can always circle back to it that, yes, I understood and I heard you when you said this, but I just wanted to present why I thought this would be an important thing or a valuable thing or a healthy thing for me to do for you. And then give them, give them the reasons why you have to, or you need to, or you should, or do the MLC. Again, like Dr. Prerna said, depending on the level of the cognition and the presence that the person has. To not stop care and start arguing about why the MLC is required at that minute would be a sensible way of approaching it. And once the rapport is built a little bit more, there's more sense of safety and security, the person might actually be okay with you going ahead and doing what you need to do and what you will do in any case. So to answer Dr. Archana's question was that, yes, we don't necessarily need to tell the patient that this is what has to be done, but it's always a good thing to let them know, okay, while I understand your apprehensions, but this is a legal process that we will do it. I'll, no harm will come to you, and explain to them, because again, every time they've already been violated, and every time you listen to what they're saying, or you're trying to convince them to do something, they might feel violated again. So that's why it's important for us to use the right word with accompanied with the right body language.
The reason why I mentioned this point is that the moment MLCs has been generated and gone to the police, it usually go to the journalists and press also. And from that, a lot of mess used to be created. I work in a government hospital and had faced that. That's why I was putting and emphasizing on this particular.
MLCs generally do not go to the police.
Usually we do not.
Leak can occur only from your hospital, then it's okay. But otherwise, MLCs don't go. It's the FIRs that go to the police.
That is why I was
not. The MLCs generally, a lot of MLCs are generated from the hospitals every day. So I think accidents, even attempted suicides and all, a lot of things. Anyway, Alim, I think we have crossed our time. The discussions will go on and on. So.
But there was one question about complex PTSD. I don't know if the chair people want to take that.
Please do as the last question then.
Sorry?
Someone wants. If you want, you can take it.
No, it's entirely at your prerogative.
I think we'll do it another time, PTSD.
Okay.
Because I have had 3 cases today who after seeing all these things on TV had their previous experiences re-enlightened. 3 cases today only, based on what they had seen on TV and what had happened. The flashbacks have started coming. So we'll discuss it. We'll put it on another day. So chairpersons, for your concluding remarks.
Okay.
Yeah, chairperson, sir.
Yes, it's my privilege or our privilege to chair the session of Dr. Ruxada and also Dr. Prerna. It's so informative and so comprehensive. We learn a lot. And from listening to your talk, I remember some of the incidences and some of the ideas I have experienced throughout this course of interaction with the patients. There were some rape cases, extremely brutal rape cases in my state also. And then first thing, in the acute cases, I think it is the responsibility of any of the doctors or any of the persons who come across such a victim, rather you don't want to call them victim, but those persons exposed to sexual assault, is to calm them, to give some comfort, and to give the sense of security. So without this, it will be very difficult to establish rapport because they are already confused, they are in the numb state, or they are very much fearful and apprehensive. They have lost the trust, and it's very difficult to establish relationship even with the doctors and the other healthcare givers. And then after crossing that stage might take longer or maybe shorter, depending on the victim as well as the healthcare giver's attitude, empathy, and how they approach. If it is Ruxeda, it will be quick, I think. She is such an expert, very calming and soothing voice also. Just a joke. And then next thing, we should not forget about the safety of the victim also, because if the perpetrators are a very what you call wicked people, or a group of very strong people, or a group gang, and they will not leave the victim alone. They will try to erase these thing evidences, even the victims. Many and incidences were there where the victims were killed and burned and tried to destroy the evidences. That though rare, it should not be forgotten, and we should take care of this also. That's what I feel. Another thing is the risks of suicide should not be forgotten. At a certain point of time, at the acute stage or somewhere down the line, we have to think about the assessment of suicide risks, and we should always keep in the back of the mind. And the last thing, most of the long-term trauma is not only because of the trauma at the incidents, but the trauma of leveling and blaming the victim by the society, even by the family members, disown them, and it will affect the marriage market so much that it is a very, very risky proposition in many of the cultures and traditions, even though they are the innocent people and it is not their fault, and they used to suffer more than the rapist, more than the perpetrators. The suffering is more with the victim. So we are very sorry for that, but it is the state of uh, the the current status in our society. And another thing is that they have lost the trust for the opposite sex, and it disturbs the law and the sexuality as well as the relationship with opposite sex, even after the marriage. That's very frequently we come to know how sometimes they refuse to get married at all. So these are long-term complications, both psychological and social aspect, that is being doing rounds in our society. So this topic is not only medical, psychological, but it's also social aspect, legal. We have well covered today because of Prerna. Thank you, Prerna. Your contributions. We have learned a lot, because this is where we are very weak. We don't bother much about reading and gathering informations about this. And these few points, it comes to my mind after listening to the today's very in time and very important topic, which is seldom taken up in any of the platforms. Thank you very much, the organizers. I will hand it over to Archana. Archana, it is your time.
Thank you, sir. It was very well conducted and very informative session. And we learned a lot. The way the practical aspects of this particular very sensitive issue has been taken and deliberated. It was wonderful. Always a delight to listen to Ruchita ma'am, as usual. And Dr. Prerna, your contributions were marvelous. We learned a lot in terms of legality also. Thank you to Pankati sir, Shal sir, Halim boss, Amrit boss for having me here. And with this, I'll end up. Back to organizers.
Thank you. Tufan sir, any comments from you?
No further comments. I realize it is delayed. Have a good night. Have a good dinner. I don't proceed
Amrit.
because there are a lot of points. Maybe
Vishal
next time.
kuch bolega. Vishal, anything?
Vishal bhai.
Okay.
Next
So
time.
thank you so much. So let me end. You know, when I and Alim were discussing what to do, we had to, you know, change the topic, because we thought this is the, and at Musings we are always, you know, on the, you know, whatever is the prime issue, we try to cover it up. Sometimes requesting senior people to readjust the dates and the times, and people have been very cooperative. This was the burning issue, and I thought that this needed to be focused. So thank you, Rukshida, for, you know, accepting our invitation or our request or our whatever you might tell so soon. And Prerna, you were so wonderful. Thank you so much for, you know, giving us in detail what to do, what not to do. So we had two great chairpersons, Lenin sir, Namaskar, and Archana, so wonderfully conducted. So thank you, Tufan sir. Thank you, Vishal. And thank you, Alim.
Ajit sir,
I thought
we'll take
Alim
a
was really
question next
making me
time.
quiet, but I am seeing Vishal has also become quiet by Alim's consistent questioning. So हम लोग दोनों छोड़ते हैं उसको वही खेल ले game. So good
That
night,
question
and
you
I
did
hope
not ask,
the whole
Rajiv sir is
exercise
saying.
goes a
Yeah.
long way in, you know, making us to be kinder and gentler and more sensitive when we address issues which are so important. And good night, everybody. Hope justice prevails. Hope
Yes.
the doctors get our share of whatever it is. So thank you all. Good night. Have a wonderful weekend. See you in Mumbai. I'm coming to Mumbai this Sunday. So meet you there. Till then, have a great time.
Good night.
Good night.
Good night.
Thank you. Rajiv sir, we'll take your question to the chairperson.
Yeah. Next time we'll take it.
Thank you. Thank